Hello, everybody, and Happy New Year. My name is Elena Sturman. I am the President and CEO of the Glaucoma Foundation. January is Glaucoma Awareness Month, and we are pleased to welcome you all to our first talk of the year, Dispelling the Myth of Glaucoma Surgery, What Each Patient Needs to Know, with Dr. Poonam Misra. Before we begin our webinar, I would like to thank Glaucos for sponsoring it. Glaucos is an ophthalmic medical technology and pharmaceutical company that focuses on novel therapies for the treatment of glaucoma, corneal disorders, and retinal disease. I would like to give a special shout out to Brandy McCracken and Cody McKenzie. I deeply appreciate our partnership. Tonight, Dr. Misra will talk about injectable medications, laser treatments, minimally invasive glaucoma procedures, and traditional filtering surgery. Some of it may be relevant to you, others may not be. We hope that with a better understanding of each of them, you will be able to talk to your doctor and develop a treatment that works best for you. Dr. Misra is a glaucoma specialist at Manhattan Eye, Ear, Throat Hospital of Northwell Health, where she is also a co-director of the Glaucoma Fellowship. In her clinical practice, she focuses on adult glaucoma, comprehensive ophthalmology, and cataract surgery. She is a member of American Glaucoma Society, American Academy of Ophthalmology, and Women in Ophthalmology. She has also particular interest in teaching medical students, residents, and fellows, and she volunteers as an examiner for the American Board of Ophthalmology. As always, there will be time for questions and answers at the end of our session. You can ask a question by using chat or Q&A button, and we will do our very best to answer as many questions as we can. Now, ladies and gentlemen, it is my great pleasure and honor to welcome Dr. Poonam Misra. Let's begin.
Good evening, everyone. Thank you, Elena, for the invitation and the opportunity to speak this evening. I want to just discuss a lot of the things that might be unknown or maybe unsure of when patients are listening to ideas of glaucoma surgery and dispel some of the myths that we may have. So as Elena said, I am a cataract and glaucoma specialist. Some of the things I'll be discussing are listed here, and we'll go through each of these myths a little more in detail. But before we begin, I want to just discuss what is glaucoma. As many of you know, and this is common knowledge to a lot of our patients, glaucoma is an optic neuropathy where the optic nerve has composed of retinal nerve fiber and ganglion cells, which are lost, which can lead to a loss of peripheral or central vision. The only known modifiable risk factor is intraocular pressure, and we're going to be discussing a lot about how we modify that. But in terms of glaucoma, on the image on the right, you can see what a healthy optic nerve looks like on the left, where there is a circle in the middle of these feeding blood vessels within the retina. If you notice, this circle has a very robust and thick rim of orange pinkish tissue, versus the nerve on the right has very little of that tissue. You can also see how the blood vessels on the healthy optic nerve are traversing over that healthy tissue, versus on the right optic nerve, the vessels don't have very far to travel. That loss of the healthy rim tissue is the structural damage we see with glaucoma. You may have been having tests called an OCT, which is a structural assessment of the nerve. That is measuring this tissue, which is lost at different rates in glaucoma. The rate of progression is something we'll discuss further, but ultimately in severe disease, the loss of tissue can be very severe. Another term you may have heard of is called glaucomatous cupping. Cupping refers to the fact that the inner circle in a pale yellow color, if you notice here, can increase over time when you have glaucoma. This is another way of explaining that the healthy rim tissue is lost. So the internal section here, the cup, gets larger. So you may hear your doctor talking about cupping, and that's what they're referring to. The optic nerve is composed of 1.2 million retinal ganglion cells. These cells are crucial for spatial contrast, color, motion, flicker, fine and coarse texture differentiation, and absolute light level. I say this to mention that the loss of tissue in glaucoma doesn't simply mean you can't read the chart. but the loss of certain very crucial aspects of the vision are things patients may not realize will happen with glaucoma, particularly contrast sensitivity. So what is intraocular pressure? Since that's what we will be talking about is kind of our goal in doing any sort of treatment for glaucoma. In our eyes, there is a gland called the ciliary body, which produces a fluid named aqueous. That fluid travels within the eye through our pupil and must exit through something we call the angle or drain of the eye. I will often tell patients the eye is like a sink, where there is a faucet that is on, producing aqueous, and a drain where it must leave the eye. In some forms of glaucoma, that angle or drain is too small, which is a form of narrow angle or angle closure glaucoma, or the angle may be open but not functioning well. In either case, the fluid is not able to exit the eye in a sufficient manner and the pressure goes up. Now I have here an image of a target because the target eye pressure is very important for any patient. In some patients who have no evidence of optic nerve disease, their pressure may be in the low 20s and we would not necessarily be concerned. In some patients whose disease is progressing despite a quote unquote normal intraocular pressure, their target may be very low, even as low as 10 to 12. So the target for your intraocular pressure as a patient is something to discuss with your doctor and to keep in mind when selecting a procedure. Now, the first myth we'll discuss is that my vision will deteriorate from glaucoma surgery. Glaucoma surgery can be combined with cataract surgery, which is important to consider because cataracts will also lead to a diminishment in your vision. So after glaucoma surgery, if you've also had your cataract removed, you may very well appreciate a great increase in your vision versus if you had glaucoma surgery alone, in which the goal is simply to lower the eye pressure and not necessarily an improvement in your vision. That being said, if you have a significant cataract, you might notice a larger improvement in your vision after surgery because that was masking some of your vision loss. There are different lenses that are used during surgery, and the decision of which lens to use is also important in evaluating what your visual outcome will be. But the most important I would find in terms of the determination of your vision after surgery is the degree of your glaucoma prior to surgery. And so I'll say this several times that understanding your disease and the degree of your disease is very important. Unfortunately, patients who have very severe disease prior to surgery may feel that their vision deteriorates from surgery. A lot of times, this is more due to short-term intraocular pressure fluctuations after the procedure. The pressure may increase or decrease based on the type of procedure that was done and the type of healing that is required. Sometimes the cornea can also have swelling after any surgery, and that can lead to a diminishment in vision, which will improve over time. What I will say is that your vision after surgery may need time to rebalance. A lot of patients, for example, who may have very limited peripheral vision, such as the visual field on the right here, may find that it takes time to find their sweet spot after surgery. You may be used to, and the brain may have become accustomed to looking out of a very small island of vision, and any surgery can throw that off for a short period of time. So having patience and monitoring closely after surgery is very important. Although it may feel like the vision has worsened, it may take time for it to reestablish itself. Another myth we often hear and patients are often concerned about is that they cannot move after surgery or that there will be other severe restrictions. I've listed here several of them, which we'll go through. Now, I want to mention there are some surgeries in ophthalmology, specifically cornea and retina surgery, where positioning can be very important. Glaucoma surgery often does not have the same strict restrictions in positioning, but there are some restrictions that are important for the healing. Heavy lifting, bending, and straining are often advised or not advised because increasing the pressure inside the body can lead to increases of pressure in the eye as well. Overstraining can cause the very fragile sutures that we use during surgery to break earlier than we anticipate, which can lead to undue fluctuations in the pressure. Avoiding oomph activities. So I say this because anything that makes you have to engage your core in a very unusual way, again, is going to increase your pressure, and we would like you to avoid that. Most patients will go home after surgery with a clear eye shield with perforations, depending on the type of anesthesia that was given. And so your vision will be a bit blurry after the surgery, but this shield is to protect the eye from any physical trauma. Especially when you're sleeping, there may be some unexpected rubbing around or on the eye. And like I mentioned, some of the stitches in the eye are very fragile, so we would like you not to touch those. What we're trying to do is prevent any significant decrease in the pressure by rubbing of the eye. Decreases in pressure can lead to problems such as bleeding and a decrease in vision. And along the same lines, we'd like patients to avoid any contact sports because any pressure on the eye can lead to complications. Pain. This is a very common question that we get. Now, pain after any surgery can be multifactorial. In glaucoma surgery, there are oftentimes stitches used, which are often as thin as a hair, but if you may have experienced an eyelash in your eye, that can still be very painful. Stitches sometimes will dissolve on their own. We do use absorbable sutures, and sometimes they are non-absorbable. Most of these stitches will dissolve or at least soften within the first couple weeks after surgery, but until that time, you may feel some discomfort. Usually we will give patients drops or ointments that will help soften the stitches, and that will make them much more tolerable. Now, in certain procedures, which I'll go into a little more detail later, we are manipulating some of the muscles of the eye. So on the right here, you can see an image of the muscles that we call the rectus muscles. These are muscles that help move the eye in different directions. The image on the bottom is of 2 glaucoma implants that we'll discuss later as well. But if you look at the image on the right, the Barrevelt shunt, that implant is placed beneath 2 of the muscles that move the eye, depending on where the implant is placed. These muscles can be sore after surgery, and even if you move the eye after surgery, engaging these muscles, you may feel discomfort. That soreness should improve over time. The final thing in terms of pain is that the corneal surface can become drier or irritated after any procedure. The medications we use and the antiseptic we use to prevent infection can dry out the eye significantly. In most cases, lubricating the surface of the eye will help ease some of this pain, but it's always important to ask your doctor what drops are safe to use after surgery. Now, I want to mention anesthesia in glaucoma surgery. In most cases, you're going to be given an IV, an intravenous sedation, and a medication that will give you a twilight sensation. If you've had a colonoscopy or an endoscopy before, it's a similar type of anesthesia. This medication will often also make you forget what may have happened during your surgery, which is sometimes helpful. But this medication is meant to not be too strong so that you're able to go home after surgery. In most cases, that's what would be ideal. We also inject anesthetic medications around an implant or around the site of surgery to keep you comfortable. In the very beginning of surgery, we will give lots of topical anesthetic drops similar to what you receive in the office, and this will help keep the eye calm as well. Now, the next myth is that a tube shunt or trabeculectomy are the only procedures of glaucoma. Now, a tube shunt and trabeculectomy, as I'll discuss with you later, are incredible procedures. They are sort of our gold standard procedures when it comes to glaucoma. They're very effective at lowering the pressure, but luckily, especially with the diversity of research and development, we have a lot of other procedures that we can do as well. I have in our glaucoma toolbox here broken up procedures into office-based procedures and operating room procedures. I'll start with office-based. Several of these procedures you may have had, or maybe you're hearing about for the first time. There are multiple lasers that can be done to treat glaucoma. The most commonly done for open-angle glaucoma is a selective laser trabeculoplasty. As I mentioned earlier, the drain of the eye has a covering that we call the trabecular meshwork that covers the angle. That trabecular meshwork is almost like a filter, if you can think of like an air conditioning filter, which has multiple spaces within it. Selective laser trabeculoplasty or argon laser trabeculoplasty are meant to try to modify that front-facing filter so that fluid that must travel into the angle or into the canal, which we'll discuss shortly, is able to do so more efficiently. In certain types of glaucoma, such as narrow angle glaucoma, where that drain is not open enough, a laser peripheral iridotomy may be done, which is making a shortcut for the fluid to pass through the eye. Drops are a mainstay of therapy. We now also have intracameral implants, of which there are more and more coming thanks to innovation and technology. One of the ones you may have heard of is Durista, which is an intracameral bimatoprost implant that secretes the medication on its own through a small pellet. That pellet is injected in the office, which takes about 30 seconds, and then the patient is monitored. These implants can release the medication and have been shown to work for sometimes up to 6 months or even a year, eliminating the need for that specific eye drop. In patients who have significant allergies to eye medications, who have trouble instilling drops or obtaining the drops, these intracameral implants are amazing and life-changing. Transscleral cyclophotocoagulation is a laser procedure which can be done in the office or in the operating room. This procedure is done to decrease how much fluid the eye produces. On the right, you'll see endoscopic cyclophotocoagulation. These are sister procedures, whereas one is done endoscopically inside the eye versus one is done from a probe on the outer surface of the eye. These procedures or lasers are targeting the ciliary body, which I mentioned produces fluid in the eye. So again, if we go back to the analogy of a sink, we're trying to turn off how much fluid is coming through and turn off that sink if we're not able to modify the drain. In terms of operating room procedures, an intracameral implant that has recently been approved, the iDose, is an implant which also secretes a medication to control eye pressure, but has been shown to work for up to 3 years. Now, this procedure does need to be done in the operating room at this time, so it is one thing to consider with your doctor. We also have a number of trabecular meshwork bypass stents. So the trabecular meshwork, again, is that opening to the drain of the eye. So bypassing it will allow the fluid to leave the eye more efficiently and lower the pressure. Goniotomy is a procedure where we are unroofing that trabecular meshwork or incising that trabecular meshwork. Canaloplasty, I'll go into next in a few more details, but is opening the drain beyond the trabecular meshwork. We also have suprachoroidal stents, which bypass the entire drainage system completely to lower the pressure. And then Zell gel stent, which you may have heard of, is a bleb-forming procedure where a small stent is placed in the eye and drains the fluid under the conjunctiva. Trabeculectomy and tube shunt, as I mentioned, are the gold standard procedures for glaucoma. These are incisional surgeries where we are creating a new drain inside the eye, so we are completely bypassing the natural system. I mentioned about the laser therapies we have, but I wanted to show an image here. In the middle image, these figures are showing a probe being placed on the outer surface of the eye. This is how transscleral cyclophotocoagulation is done. The eye is numbed, and then the probe is placed on the eye with the short pulses of energy or continuous energy, which is trying to turn off the production of aqueous by the ciliary body, which is underneath the probe in these images. On the right, you see an endoscopic view where a probe is actually placed into the eye. And if you look at these teeth-like structures, these are the glands that are producing fluid. When we are lasering them, we can actually see them shrink, and that is how we know that the laser has taken effect and the pressure is hopefully lowered. These procedures can cause inflammation inside the eye, and so the postoperative management is very important. I want to mention that selective laser trabeculoplasty is a very effective procedure to avoid eye drops, which is a common question of how long will I need to use eye drops. This procedure works in about 80% of patients on average to lower the pressure by anywhere from 20 to 25%. It has also been shown to decrease the fluctuations in the pressure. In terms of how the pressure affects the optic nerve, I often use the analogy of a trampoline, where the optic nerve is sort of always undergoing the pressure that is created by this fluid within the eye. The optic nerve does not like when the pressure is consistently elevated, but it also does not like when there are great fluctuations. And a common conversation we have in all of our meetings is whether it is better to stabilize the pressure absolutely or the fluctuations. And I think both are very relevant. This laser is really excellent at reducing some of those fluctuations, on top of also reducing the need for drops if it is effective. Now, there are some cases where this is not an appropriate procedure. In many cases of active neovascular glaucoma or uveitic glaucoma, which is related to inflammation, we do not recommend this laser. So very important to speak with your doctor about what your type of glaucoma is to see what's important and appropriate for you. Now, many of you have probably heard of MIGS surgeries. Minimally invasive glaucoma surgery is really at the forefront in glaucoma right now. We have a lot of new options, and every day it seems like there are more, which is understandably very exciting, but it's very important to know what procedure is appropriate for you. In general, these MIGS procedures are found to have a better safety profile because there is usually a smaller incision during these surgeries. The recovery time is often shorter than a trabeculectomy or a tube shunt. There is a less risk of bleeding, although I will explain a little bit later on how bleeding is always going to be a risk with a lot of these procedures. And the operating room time is often shorter with some of these MIGS surgeries. On the bottom right image here, this is a picture of the angle. So if you can appreciate, there are sort of three stripes here. The middle stripe is the trabecular meshwork, which is where the opening to the canal, which is beyond this structure, is. When we are incising this tissue, we are trying to enter the space where fluid will ultimately leave the eye. And whether we are unroofing this space or cannulating this space, the goal is to maximize the amount of fluid which is leaving to lower the pressure. The top here image is an image of one of the implants we may use to do this, just to give you a sense of the size scope of what we're looking at. Now, again, granted, we are under a microscope. This would be pretty hard to see if you were outside of the eye. Angle-based surgery is another term for this minimally invasive glaucoma surgery group of procedures. I will discuss in detail some of the ones on the bottom of my list here, but I quickly want to mention that one of the intracameral implants, which is a depot of medication called the iDose, is pictured here on the right. This stent is placed in the operating room into the trabecular meshwork. You can see the size comparison to the center of this finger here. This is going to secrete medication for up to 3 years. This is barely visible to the naked eye. So technology is expanding very quickly to have more implants such as this. Next, we're going to talk about what opening the canal will mean. So canal of Schlemm is this circular structure that goes 360 degrees around the eye. The angle we discussed is the entry point into this canal. So the angle is also 360 degrees. The fluid flows, as these white arrows are showing, into the canal of Schlemm and into blood vessels that are then going to leave the eye and lower the intraocular pressure. One of the procedures we discussed is canaloplasty. Canaloplasty is trying to open this canal. So a catheter is inserted into the canal. For example, this is a picture of an Omni stent. It threads through the canal, almost like flushing the gutter of the eye, and to eliminate any blockages and make sure that fluid which needs to pass within this circuit is able to do so freely. We can also unroof the trabecular meshwork, as I mentioned, which is a goniotomy. And if you can appreciate here on the left side of this image, there's a big opening where you can see the white wall, which is the back of Schlemm's canal, as this blade passes across the trabecular meshwork. Some of the stents that we may use may help open the drainage system and open the canal. And we also have stents such as the Hydrus, which will hold the canal open. This stent is placed into the canal and then maintains it open, almost as if an angioplasty or a stent is placed in our cardiac system. We also have some stents, excitingly, that are going to bypass this entire system, which are called suprachoroidal stents, such as the AlloFlow or MiniJect. The anatomy of a patient's eye is very important in deciding which of these procedures is appropriate. If under examination in the clinic, we are not able to appreciate sufficient room to place these stents, we will not offer those procedures. So it's very important to discuss with your surgeon what procedures you may have heard of or what you may think would be appropriate, but what is best for your eye in particular. Over here, I wanted to show when an implant is in the eye, how things may appear. The stent I showed here, the Hydrus stent in the middle image on the right, is now shown implanted within that canal. So if you remember those 3 stripes I showed, the implant is rather large, but it is sitting behind that middle stripe, and it's going to hold open the canal in that area. Now, some of these stents are only covering a certain portion of the 360 degrees of meshwork. And so this implant in particular would cover about 3 clock hours or 90 degrees of that 360 degrees. The positioning needed to place these stents does sometimes limit how extensive we can treat, but we can also do several of these procedures over time if necessary. On the bottom here is an interesting image where this blinking red light is actually part of a catheter. If you notice this fine line here, that is injected into that canal. And if I can go back for a moment to show you, that blinking light is injected here, and the blinking light shows the catheter as it travels 360 degrees around the canal. This is again stenting open the entire canal, and on the way out, when the catheter is removed, a viscoelastic or a jelly-like substance is injected to try to push open not only the canal, but the further downstream channels that are collecting the fluid. So we have several new technologies to be able to do these procedures very safely, which is why a lot of times we discuss that angle-based surgery or minimally invasive glaucoma surgery can have a better safety profile. So why not MIGS, or when are they not indicated? Because again, knowing when and what procedure to do is very important, and it's a crucial part of our training. The effectiveness. Unfortunately, we are still collecting data on some of the long-term efficacy of these procedures. Unlike cataract surgery, where once the cataract is removed and then we don't expect it to come back, glaucoma is something that will be a lifelong disease. And so the longevity of each procedure is very important. And while we would all love to say that this will be the last procedure you will need in your lifetime, unfortunately, there may be a time for each and every one of these procedures for you. Understanding the effectiveness and what are your goals are important with your surgeon. I mentioned earlier on that a target intraocular pressure should be discussed. Now, that number may not stay the same for the entirety of your disease, but understanding whether you need a 5-point reduction in your pressure or a 15-point reduction is very important. A lot of these procedures do have excellent IOP lowering outcomes. However, how long it will stay that way and whether you may still need a drop is important to consider. Accessibility to the natural drain of the eye, or to Schlemm's canal. This has to go back to the anatomy that I mentioned earlier. If we're not able to visualize the canal or the trabecular meshwork, some of these MIGS procedures are not going to be appropriate. There are certain forms of glaucoma I mentioned earlier, such as chronic angle closure glaucoma. A lot of times you may have developed scarring which has closed off that angle or drain, in which case it is possible to try to open them, but we may not be able to stent it or place some of the implants that we've been discussing. Positioning. During surgery for some of these minimally invasive surgeries, we often ask patients to turn their head during surgery to the right or left. Patients with certain neck issues or spine issues may have trouble doing so. And as we try to keep anesthesia minimal during these surgeries, we are not able to force the eye or the neck into the right position for surgery. So discussing that ahead of time is another important aspect to planning for surgery. And then the final option is that surgery can be combined with or without cataract surgery or done as a standalone procedure. Some of these MIGS are indicated with cataract surgery or without, and some must be done with cataract surgery. It's important to discuss that as well and know if you're going to be doing a combined procedure. Now, trabeculectomy and tube shunt are two of the gold standard surgeries. In trabeculectomy, we are bypassing the natural system, the natural canal of Schlemm, and creating a new opening within the tissue. So in the white part of the eye, we are creating a small opening through which fluid is going to drain. The fluid is then collected under the conjunctiva or the skin of the eye. Over the white part of the eye or over the sclera, there's a skin that has several blood vessels that you will notice. And underneath that is where the fluid will collect, creating what we call a bleb. You may have heard of a bubble or bleb. Fluid collects there so that it is not trapped within the eye. Over here on the right, you can see an image of the fluid, which is going to exit through the eye through this white pathway, and then must travel underneath this flap that we are monitoring after surgery. Unfortunately, the body cannot recognize a good cut from a bad cut and oftentimes creates scar tissue around the edges of this flap. After this surgery, there is a close follow-up that must be maintained. I will often tell patients they must come in and see me every week for the first 4 to 6 weeks after surgery to monitor for the rate and progression of any scar tissue that's formed. This trap door or flap is closed with several very fine sutures. These sutures, again, are the thickness of a hair. They can be lysed or broken with a laser in the office, or they can be cut with a needle in the office. These procedures are determined based on the rate of healing, and which is why we need to have such close follow-up. A trabeculectomy will require a longer period of healing, and the restrictions that we discussed earlier are usually applicable for about 4 to 6 weeks after surgery. However, a trabeculectomy is incredibly effective at lowering your eye pressure. Most patients will stop all of their glaucoma drops right after surgery, and if the surgery is successful, can often be maintained for up to 5 years without drops. Now, that is a very broad range. I will tell you that not every patient has the same outcome. Monitoring each patient and their rate of scar tissue is very important. Glaucoma tube shunt implants are another class of procedures, which are often done in patients who have more severe disease. There are 2 forms, a valved or a non-valved implant, and a size comparison here on the right gives a good depiction of how small these implants truly are. A non-valved implant is not opened immediately after implantation. The tube is actually closed for the first few weeks after surgery because we want the body to create what we call a bleb or encapsulation around the implant. The tube is placed into the eye, where fluid is then tracked through the implant and collects inside of that encapsulated bleb that will form. In a non-valved implant, we tie off the tube or ligate it so that fluid cannot go through until the body has sufficient time to create a capsule around the implant. If the tube were opened too early, the fluid would have no restriction and the pressure may drop too low. As we discussed earlier, too low pressure can lead to other complications such as bleeding that we would like to avoid. The tube can be partially opened in the first few weeks while we are waiting for the entire implant to be encapsulated, which you will discuss with your surgeon if it is appropriate for you. A valved implant, such as here on the right, is an implant that has a flow restrictor or regulator. This prevents the fluid from going through the tube in a too uncontrolled fashion and prevents too low pressure early on. The body will still create a capsule around the implant plate in the same time as with a non-valved implant, but because of the flow regulator, you would get a very early intraocular pressure control, and then ultimately the body will still create the capsule where fluid will collect. The indication for each surgery is dependent on your type of glaucoma, on the rate of your glaucoma, also based on any prior surgeries you may have had, including prior corneal or retinal surgeries, and also based on how quickly your pressure needs to be reduced. In certain types of glaucoma, such as neovascular glaucoma, where there is a sudden spike in pressure due to abnormal blood vessels growing within the drain of the eye, we may want to get the pressure low very quickly, in which case we would want an implant that's working immediately. This is an important discussion to have with your doctor, is what is your goal of your procedure. I showed this image earlier. I just wanted to go back to it to show that different implants have different size profiles. Something like an Ahmed valve is a valved implant, which is placed between the intraocular muscles. This implant is not going to be underneath the muscles like a Baerveldt implant, where there are wings to this plate which sit underneath and are secured underneath the muscles. Your decision of having surgery is dependent on your anatomy and also any previous implants. Patients can have multiple implants within the eye if their pressure is not sufficiently controlled with one implant. So which procedure is best? Unfortunately, there is no perfect procedure. The procedures I've mentioned are all very effective for glaucoma, but the rate of your disease and the rate of your healing really determines which of these is appropriate at which time. Your goals of treatment include your severity is based on your severity of disease, the rate of progression, your target intraocular pressure, and history of other surgeries. If there is a concern about post-operative follow-up or any limitations, for example, there are patients who are undergoing physical therapy who need to have certain procedures or they need to have certain restrictions based on other medical conditions. That is important to discuss with your doctor, because if you're not able to attend the frequent post-operative visits or instill the post-operative medications that are needed to ensure success, we may select a different procedure for you at this time. As I mentioned earlier, there is always the opportunity to choose a different procedure further along in your disease. There is no one procedure that unfortunately will cure glaucoma at this time. And then the recovery time. Tube shunts and trabeculectomies often do require a 4 to 6 week healing period. If that amount of time is interfering with any travel or other medical procedures, it's important to know that so that you can have the most successful outcome. One of the last myths I'd like to mention is that you will never need drops after surgery. Unfortunately, many patients will still need drops at some point in their lifetime. Many surgeries, we will stop drops initially to let the eye reset and try to give the surgery that we did a great shot of succeeding. But if we find that your pressure is still above the target, in order to preserve your vision and prevent vision loss, we may have to restart intraocular pressure lowering drops. Many of these surgeries will require long-term use of post-operative medications, such as steroids, like prednisolone, which is an anti-inflammatory medication. This prevents scarring, which I've mentioned can be one of the problems with any surgery. An antibiotic to prevent infection. A cycloplegic agent might be used, which often dilates the pupil, such as atropine or cyclopentolate, and then an ointment. The ointment is often used, as I mentioned, to soften stitches and provide comfort to the eye. So you probably will still need some drops after surgery, but understanding which drops are being used and why is very important. some general tips, because I think the final myth I wanted to discuss is that glaucoma surgery can be cured. Unfortunately, this is going to be a marathon, not a sprint. There's going to be times when your pressure is going to fluctuate despite having the most successful procedure, but knowing that there are many options out there should give you some comfort in that we are constantly advancing the treatment of this disease. Knowing your disease is very important. Understanding what procedures you've already had done, understanding what visual field testing has been done, and even having copies of it is going to be very helpful for you. It is your right to have your records, and it's important for you to know what has already been done. So keeping a record yourself or requesting your records is always appropriate. Discuss your activities, day-to-day life, and goals with your provider. If you are a swimmer, if you are a runner, if you are a weightlifter, these are all important things to know so that the surgeon can decide what procedure is going to be most successful for you. If they find that something is unsafe or is going to limit your activities and your lifestyle in a way that's going to personally affect you, they're going to make a recommendation that will be a better fit. And if they feel that something is missing in your care or that the change in your treatment is necessary, understanding your lifestyle is going to be important for them to make the right decision. Thank you so much for your time. And again, thank you for the invitation to speak today.
Thank you so much for this absolutely fascinating webinar that dispelled so many myths for patients and gives so much useful information. We have a bit of time left for questions, and people have been writing in a Q&A button, so I will start. So this is a very interesting question. When you do these procedures, do you do them at both eyes simultaneously or one eye at a time?
Most of the time, we will only do one eye at a time. There is always concern for any risk of infection with any procedure, and we would always want to avoid anything affecting both eyes and limiting your function bilaterally. I will say that patients who have uncontrolled intraocular pressure in both eyes may have surgery subsequently about a week or 2 weeks apart, but in general, we do try to avoid doing them on the same day. Now, laser procedures such as laser trabeculoplasty or peripheral iridotomies can sometimes be done on the same day. These are the non-incisional options that we discussed, but any incisional surgery would probably be unilateral only.
Thank you very much. Next question. How effective is Zen gel stent surgery?
Then gel stent is a very effective surgery. The success rates vary between 75 and 85% at lowering intraocular pressure. However, the rate of scar tissue after surgery is important to monitor for. So the length or longevity of the surgery can vary, but in general, it is a very effective procedure.
Thank you very much. Next question. I have had open-angle glaucoma for 16 years. I have used several eye drops and had allergic reactions to most. I currently use latanoprost. I've had 2 SLT surgeries, and the second surgery did not lower my IOP for too long. My last IOP was 24 in my left eye and 21 in my right eye. Do I need surgery? And if so, what type?
So as I mentioned a few times, in knowing what your anatomy looks like would be the safest way to recommend any procedure. In terms of repeating SLT, it is commonly done. In my practice, I would recommend that if you have a good response to the first procedure, then repeating it is more effective. But studies are coming out to show that even if the laser is not as effective the first time around, a repeat procedure may work in the future. Now, having allergies to eye drops is incredibly common. A lot of patients, despite using preservative-free options, despite spacing drops or using artificial tears, will still find themselves having allergic reactions. Depending on the degree of your disease, an angle-based surgery like a MIGS surgery may be helpful, but knowing whether or not you're close to your target is very important. So one thing I also may have missed to mention is that understanding the highest pressure you've ever had is very important. If your pressure has started out only a few points higher than where you are now, you may likely not be at your goal. If we only need a pressure reduction of a lesser amount, a minimally invasive surgery may get us to that goal. But if we find that your pressure needs to be reduced significantly, over 30%, then a more traditional incisional surgery may be the better option.
Thank you very much. Next question. What do you think of home tonometry?
Home tonometry is an absolutely excellent tool to have. There are different forms of it, and there are luckily different companies who are all developing their technology, but being able to understand the fluctuations in pressure is very important. Some years ago, we used to have patients come in and spend the entire day with us and check their pressure every hour of the day. That's not very practical in today's life, but home tonometry allows us to see if the patient is having fluctuations when they're not in the office. Studies have shown that 60% of the time, the highest pressure of a person has during the day is outside of the office. And so unfortunately, while we often make decisions based on the number we get in the office, we have to use that as a guide and look at your pressure range over time. Home tonometry can offer us more information, and especially to see at what point in the day your pressure might be spiking so that we can address that with the right medication.
Thank you very much. Next question. How do you select treatments for patients who are very steroid responsive?
Steroid response glaucoma is very common. Many procedures, such as corneal procedures, require patients to use steroid drops for an indefinite amount of time or very long-term use. Selective laser trabeculoplasty is very effective in steroid response glaucoma. And so in most patients, I will start with that. Drops are also very effective, but laser is oftentimes easier because they're already using so many eye drops, or perhaps they have things like corneal disease, and our glaucoma drops can often exacerbate that disease. So in my practice, I would attempt to start with selective laser trabeculoplasty if the view is sufficient to do so, meaning if I'm able to visualize the trabecular meshwork. If not, I would start with drops. Now, severe disease, unfortunately, may require incisional surgery in many of these patients, and that may include some of these MIGS procedures or a trabeculectomy or a tube shunt. But I always recommend starting with a less invasive approach first to see the response, and then we can escalate after that.
Thank you very, very much. Next question. Can you have more than one trabeculectomy?
Absolutely. So a trabeculectomy can be revised or it can be redone. The area of tissue needed for the trabeculectomy is about 2 to 3 clock hours, and we always discuss the eye as clock hours in terms of positioning. You can do another trabeculectomy, meaning make another of that flap right next to the first one, or we can go in surgically and try to cut out any scar tissue that has formed around the first surgery. So revising or redoing the procedure is absolutely possible.
Thank you very much. Next question. How effective is the eye stand?
So the iStent is a very interesting device that has had several modifications over the years to become more effective. In many patients, in about 80% of patients who are on 1 or 2 drops, there has been significant IOP reduction, meaning greater than 20%. Now, the number of drops you're using before surgery is important to know, and what are the goals after surgery. In terms of being completely drop-free, the results can vary, but there has been shown to be reduction at least 1 to 2 drops in about 75 to 80% of patients in mild glaucoma. Now, some of these devices may not be as recommended or effective in more severe glaucoma, but the latest modifications to the iStent actually have been shown to also work to reduce medication burden in severe glaucoma.
Thank you very much. Next question. How do you treat steroid responders? Knowing that the steroid drop raise pressure for those patients, can you substitute for different drops instead?
That's a great question we get asked a lot of times. So steroid drops are anti-inflammatory. There have been cases where we have tried to use non-steroidal anti-inflammatory drops in place of steroids. However, depending on the procedure that you are doing, if you are implanting a tube shunt or doing a trabeculectomy, the concern for steroid response is less because you are creating a new outflow system. And so you are not dependent on the steroid causing the problem to your natural system when you are creating a new system. If you are doing something like an angle-based surgery, the steroid use is often short-term after surgery. And so you will likely not be using it more than a few weeks, depending on your healing. And so we're not as concerned of the steroid causing a response at that time.
Thank you very much. Next question. Following numerous surgeries and procedures, my pressures now range from 4 to 6 in each eye. Is this a concern?
So the concern with low pressure after surgery and not knowing which surgery they may have had is that low pressure can lead to certain changes within the retina, something specifically called hypotony maculopathy. So if the eye pressure is too low, if the vision is intact, and if your retina is intact in terms of the structure, there is no problem with it being so low. If that low pressure leads to alterations in the anatomy of the retina, that is when you may have some visually significant issues that need to be corrected, in which case there may need to be corrective measures to raise the intraocular pressure or to modify an implant or surgery that's already been done.
Thank you very much. Next question. I've had trabeculectomy surgery in both eyes with very good results. What can happen over the years?
As time goes on after your surgery, there is always going to be a risk of scarring. And so monitoring your pressure is still just as important as prior to surgery. Now, usually we say that in those first 12 weeks after a glaucoma procedure, like a trabeculectomy or a tube shunt, that the majority healing has occurred. And so we don't expect a significant amount of scar tissue to grow after that point. However, there are cases where years after trabeculectomy, the pressure will start creeping up. Catching that pressure before it creeps up too high is very important. So understanding that you still need to be monitored, that your body is still healing is important to know. But there can be modifications like we discussed or revisions to a previous trabeculectomy to get it to restart or function again. So it does not mean that the surgery will fail, but you may need some revisions or a little help along the way.
Thank you very much. Next question. For patients with hardened and scarred cornea, how useful is checking pressure with a non-corneal tonometer?
That is a great question. So the thickness of the cornea is often discussed as one of the things to monitor for measuring pressure. An accurate pressure is difficult to achieve in a cornea with significant scarring. What I would say is that the trend in the pressure is very important. There are different ways to measure the pressure, and what I specifically like to do is trend it over time to see if there are fluctuations. As I said earlier, the nerve does not like when the pressure is very high or if it's going up and down too quickly. And so although the pressure measurement may not be exact, understanding the trend, whether it is higher from baseline or not, or it is changing in a certain static state, is important to know. There are other ways to check pressure that we have in the office between the eye care, the applanation. We have also a aura technology, which is measuring the pressure with more of a non-contact version. These are all different ways to assess the pressure. But what I would recommend is looking at the trend more so than the actual number. If you have consistent use and type of measurement, you will detect if there is a fluctuation or if the pressure is consistently high.
Thank you very much. We have time for one more question. My doctor said my drainage system could accommodate several eye stents. Can you explain that?
So the iStent device now has 3 different implants, the latest version of the iStent. These implants are placed about 2 clock hours apart within that canal system within the trabecular meshwork. And so having room to place all 3 of them is important to note. The initial iterations of the iStent actually only had 1 implant that was placed. Subsequent versions had 2, and now the latest has 3. And so having all 3 is going to give you the best pressure reduction and also optimize the opportunities to find space within the drain that can be opened up and reactivated. So having space often will mean that your angle is open, that it's accessible, and the implants can be placed safely.
Thank you very much. We've come to the end of our webinar. I would like to thank Dr. Poonam Misra so much for incredible presentation. We learned so much. It was very, very useful, and it was recorded. And as you know, with all of our webinars, you can watch it again because I know there was so much good information. You will want to watch it again. It will be available on our website and on our YouTube channel. And as always, please stay connected with the Glaucoma Foundation for information and news. Thank you so much, Dr. Misra, and good
Thank
night.
you.
Bye-bye.